There's a birthday most people never notice passing. It isn't 60. It isn't the day you retire, or the day you get your first grandchild, or even the day your knees start complaining about the stairs. It's quieter than all that. It's the day your liver and kidneys stop processing your medication the way they used to. And nobody sends you a card for it. You won't feel it happen. There's no ache, no dizziness, no warning label that flashes across your morning coffee. The pill bottle looks exactly the same as it did 5 years ago. The dose on the label hasn't changed. Your doctor hasn't said anything different. And yet, inside your body, something has shifted. And that shift can be the difference between a medication protecting your heart and that same medication quietly working against it. Today, we're going to walk through 5 categories of medication that, after the age of 60, carry a heavier cardiovascular price tag than most people realize. Some of these you may be taking right now, tonight, without a second thought. One of them is sitting in almost every medicine cabinet in the country. And by the end of this, you're going to understand not just what these medications do, but why the exact same pill can be a completely different substance in your body today than it was a decade ago. Before we get into it, I want to be clear about something, because this is not a video designed to scare you off your prescriptions. Nobody should stop taking a medication because of a video on the internet. What this video is designed to do is arm you with the right questions to bring to your doctor or pharmacist. Because the truth is, most people are never taught how aging actually changes the way drugs behave in the body. And that gap in understanding is exactly where risk likes to hide. So let's start there, with the part nobody explains at the pharmacy counter. When you're younger, your body is remarkably forgiving. Your liver processes medication efficiently, breaking it down and clearing it out on schedule. Your kidneys filter your blood with real precision, flushing out what your body no longer needs. Your blood vessels are elastic, able to expand and contract without much resistance. Your body, in other words, has margin for error. That margin shrinks with time. Not dramatically, not overnight, but steadily. The liver becomes slower at metabolizing certain compounds. The kidneys lose a percentage of their filtering capacity every decade after 50. That means a medication that used to clear your system in 12 hours might now take 18 or 20. If you're taking that same dose every single day, the drug doesn't fully leave before the next one arrives. It builds. Quietly, invisibly, it accumulates until what was once a completely normal dose starts behaving biologically like a stronger one. At the same time, your cardiovascular system is undergoing its own transformation. Arteries that were once flexible start to stiffen. The endothelium, the delicate inner lining of your blood vessels that controls how they expand, contract, and resist clot formation, becomes more reactive, more easily disrupted. The balance your body maintains between clotting and bleeding, a balance that's been on autopilot your whole life, becomes noticeably more fragile. None of this makes you fragile as a person. It simply means the environment your medications are operating in has changed, and medicine, at its core, is entirely about context. A dose that was well matched to your body at 50 may be mismatched at 70, not because anything was done wrong, but because the target moved. None of this makes you fragile as a person. It simply means the environment your medications are operating in has changed. And medicine, at its core, is entirely about context. A dose that was well matched to your body at 50 may be mismatched at 70, not because anything was done wrong, but because the target moved. Here's the uncomfortable part. Prescriptions rarely move with it. Once a medication is established as part of your daily routine, it tends to stay there. Nobody revisits it unless something goes wrong. Doctors aren't being careless. They're managing dozens of patients, and unless a red flag appears, a stable prescription tends to stay untouched for years, which means the responsibility for asking, does this still make sense for me now, often falls on you. So let's go through the 5 categories where that question matters most, starting with one so common, you've probably reached for it in the last month without thinking twice. The first is the family of pain relievers known as NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. Several prescription-strength anti-inflammatories fall into this group too. If you've ever taken something for a stiff back, an aching knee, or a headache that wouldn't quit, there's a good chance it was one of these. Here's how they work. NSAIDs block enzymes responsible for producing inflammation, which is exactly why they're so effective against pain and swelling. The problem is, those same enzymes play a second, quieter role. They help regulate blood vessel tone and support kidney function. And when you interrupt that system, you're not just turning off pain, you're also nudging your blood vessels toward constriction, which can raise blood pressure. At the same time, your kidneys may start holding on to more sodium and fluid than they should, adding extra volume for your heart to push around. In a 30-year-old body, this effect is usually negligible. Flexible arteries absorb the change without complaint, but in a body past 60, where the arteries have already lost some of their elasticity, That same nudge can translate into a real and measurable rise in blood pressure, one that doesn't announce itself with symptoms. You won't feel your arteries tightening. You'll just notice, months later, that your blood pressure readings have crept upward, and you might never connect it to the ibuprofen you've been taking most nights for your knee. Large population studies have repeatedly linked frequent, long-term NSAID use to a higher risk of heart attack and stroke, particularly in people who already carry cardiovascular risk factors like high blood pressure or prior heart disease. That doesn't mean NSAIDs are dangerous by nature. Used occasionally for a few days here and there, they're generally well tolerated even later in life. The risk climbs specifically with daily, ongoing use that never gets reassessed, the kind where a bottle just quietly becomes a permanent fixture on the nightstand. Now, let's talk about something even sneakier, because at least with NSAIDs, the mechanism is somewhat intuitive. This next one catches almost everyone off guard. Proton pump inhibitors, PPIs, are medications like omeprazole and esomeprazole, prescribed constantly for acid, reflux, heartburn, and stomach protection. If you've ever been told to take something for your stomach alongside another medication, odds are good it was a PPI. They work by dramatically reducing stomach acid production, which sounds purely beneficial. Less acid, less burning, less damage to the esophagus. Simple. Except stomach acid isn't just an irritant waiting to be shut off. It's essential machinery. It helps your body absorb magnesium, calcium, and vitamin B12, suppress acid production for months or years at a stretch, and those absorption pathways start to weaken. You may never notice the deficiency directly. There's no dramatic symptom that says your magnesium is low. But magnesium happens to be critical for maintaining a stable, regular heart rhythm. When levels drop, the risk of arrhythmia, an irregular heartbeat, rises. Calcium imbalance affects how your blood vessels function. And vitamin B12 deficiency has its own documented links to vascular health and nerve function. There's a second layer researchers have been investigating. Some evidence suggests long-term PPI use may interfere with how the endothelium, that same delicate vessel lining we talked about earlier, regulates blood flow and clotting. If that regulation weakens, the vascular system becomes more susceptible to problems it would otherwise have handled without issue. The pattern here should sound familiar by now. Someone gets prescribed a PPI for a short-term flare of acid reflux. It works. The discomfort disappears. And because nothing hurts anymore, nobody thinks to ask whether they still need it a year later or 5 years later. It sits quietly on the daily medication list, doing its job on the surface while working against nutrient absorption underneath. That brings us to something entirely different in nature. Medications that don't just interact with your chemistry, but directly with how alert, mobile, and responsive your body is throughout the day. Benzodiazepines are the third category. Medications like diazepam and lorazepam, commonly prescribed for anxiety, sleep, difficulties, or a nervous system that just won't settle down. For a lot of people, especially later in life, these medications feel less like a drug and more like a lifeline. They work fast, they work reliably, and that reliability is exactly what makes people stay on them far longer than originally intended. Here's what's happening physiologically. Benzodiazepines slow activity across the central nervous system. That's the entire point. It's what produces the calming, sedating effect. But the nervous system doesn't just control anxiety and sleep. It also governs breathing rate, reaction time, muscle coordination, and alertness. Slow the whole system down, and all of those get dampened along with the anxiety. Age changes how strongly this hits. Older bodies clear benzodiazepines from the system more slowly, meaning the sedative effect lingers longer and can even build up with repeated daily use, even without any dose increase. Practically, this often shows up as reduced physical activity. More time sitting, more time resting, less spontaneous. Movement throughout the day. That might sound harmless, but circulation depends heavily on movement. Less movement means blood pools more easily in the extremities, circulation becomes less efficient, and the risk of clot formation edges upward. Oxygen delivery to tissues becomes less optimal too. There's another thread worth pulling on. Benzodiazepines can suppress breathing during sleep, sometimes worsening undiagnosed sleep apnea or simply making breathing shallower overnight. Repeated dips in blood oxygen while you sleep place real, measurable stress on the cardiovascular system, the kind that accumulates over months without ever producing an obvious symptom you'd think to mention at your next checkup. You just feel a little more tired than usual, a little slower in the mornings. It gets chalked up to getting older, when it may actually be a medication effect that's compounding quietly, night after night. None of this means someone with genuine anxiety or insomnia should white-knuckle through it without support. It means the same question keeps resurfacing. Is this still the right tool at the right dose for where my body is now, or has it just become habit? Now for the fourth category, and this one tends to genuinely surprise people because it's sold without a prescription and treated like something you'd barely think twice about. Decongestants. Medications containing pseudoephedrine, along with a long list of combination cold and allergy remedies, are everywhere. Cold season hits, sinuses clog up, and reaching for one of these feels about as consequential as reaching for a tissue. Their mechanism is straightforward. They constrict blood vessels, which is exactly what shrinks swollen nasal tissue and clears congestion. The catch is that decongestants don't know the difference between the blood vessels in your nose and the blood vessels everywhere else in your body. That same constricting effect happens throughout your circulatory system, including the vessels feeding your heart. Constricted vessels mean higher resistance, which means higher blood pressure and a heart working harder to push blood through a narrower path. In a younger, more elastic vascular system, this is generally tolerated without much issue. In a body past 60, where arteries have already stiffened, that added resistance can matter, especially for anyone already managing high blood pressure or heart disease. And here's where things get genuinely risky. Decongestants rarely show up alone. Someone managing blood pressure with one medication, taking a pain reliever for arthritis, and using something for sleep already has 3 systems interacting quietly in the background. Add a decongestant during cold season, and now you've got a 4th variable. Stacked on top, one raising blood pressure, another affecting fluid retention, another slowing the nervous system down, and the body attempting to compensate for all of it simultaneously. This is precisely why cardiovascular events at this age so often feel like they came out of nowhere. The person having them will tell you honestly, I felt fine yesterday, and in a sense, that's true, because the strain wasn't building in a single dramatic moment. It was accumulating quietly across weeks or months, through a stack of individually safe medications interacting in ways nobody was tracking. Which brings us to the 5th medication. And this is the one that tends to land hardest because it isn't obscure or rarely used. It's the opposite. It's one of the most trusted, most recommended, most habitual medications in the entire world, low-dose aspirin. For decades, a daily baby aspirin was standard advice, a simple, inexpensive way to protect the heart by preventing blood clots. And for a specific group of people, that advice still holds completely true. Those who've already had a heart attack, a stroke, or who carry a confirmed high-risk cardiovascular profile. For them, aspirin remains a genuinely protective, well-supported choice. But more recent research has reshaped the picture for a much larger group. Adults over 60 who have never had a cardiovascular event and are simply taking aspirin as a precaution. In that population, several major studies have found the protective benefit is often smaller than once assumed, and in some cases, the risks may actually outweigh it. Here's the mechanism. Aspirin works by making platelets less likely to stick together, which reduces clot formation inside arteries. That's genuinely useful when clotting is your primary danger, but clotting isn't purely a threat. It's also how your body stops bleeding when a blood vessel is damaged. After 60, blood vessels become more fragile, and the lining of the digestive tract becomes more vulnerable to irritation. When aspirin dials down your body's clotting ability in that environment, it can meaningfully raise the risk of internal bleeding, particularly in the stomach or the brain. This is where the nuance becomes genuinely important. Stroke isn't a single category of event. It comes in 2 very different forms. One is caused by a clot blocking blood flow to the brain. The other is caused by bleeding inside the brain itself. Aspirin reduces your risk of the first kind, but by thinning your blood, it can increase your risk of the second kind. For someone with a clear cardiovascular history, the math usually favors taking it. For someone without one, especially past 60, that balance can tip the other way. And updated clinical guidelines have increasingly reflected exactly that shift. The trouble is, most people who started daily aspirin years ago did so under older Guida. NCs and simply never revisited it. It became a habit rather than an active medical decision, something taken just in case, without ever confirming whether just in case still applies to their current risk profile. And taking a medication just in case, when it no longer matches your situation, means absorbing real risk without gaining real protection in return. So now you've heard all 5: anti-inflammatories, acid reducers, sedatives, decongestants, and aspirin. 5 completely different mechanisms, 5 completely different symptoms, or rather, the absence of symptoms, because that's really the common thread running through every single one of them. None of these risks show up with a dramatic warning sign. They build in silence through blood pressure that creeps up a few points at a time, nutrient levels that drift downward over years, circulation that slows without anyone noticing, and a clotting balance that shifts one imperceptible degree at a time. This is exactly why the solution isn't panic, and it isn't tossing your medicine cabinet in the trash. The solution is re-evaluation, treating your medication list as something that should evolve alongside your body, rather than something fixed in stone from the day it was first prescribed. Here's what that actually looks like in practice. Start by scheduling an honest medication review, ideally once a year, even if nothing feels wrong. Bring an actual list. Every prescription, every over-the-counter product, every supplement, and ask directly, does this still make sense for me at my current age and health status? Is there a lower dose or safer alternative available now that wasn't when I first started this? Single pill in isolation? It's caused by several medications quietly compounding each. Watch for the subtle signals your body actually does send, even if they're easy to dismiss. Fatigue that seems disproportionate to your day. Dizziness when you stand up. Proof that something is wrong, but they're worth mentioning to your doctor, rather than filing away under just getting older. Metabolizes differently. It responds to stress differently. It has less margin to absorb small mismatches, which means the same dose, the same combination, the same routine that served you well for a decade can quietly stop being the right fit without anyone ever formally deciding to change it. Then it gets. Not everything is about adding a new treatment. Sometimes the most valuable medical decision is adjusting, reducing, or discontinuing something that no longer earns its place. And that process deserves exactly as much care as starting a new prescription does. Once you see it this way, the whole conversation shifts from something worrying into something genuinely empowering. You stop viewing your medications as permanent fixtures and start seeing them as tools that need to match the current version of you, not the version you were a decade ago. When that match is right, these medications do exactly what they're meant to do. When the match drifts, even slightly, that's where risk quietly moves in. So here's something simple you can actually use. At your very next doctor's appointment, instead of only discussing new symptoms or new prescriptions, ask one direct question. Is everything I'm currently taking still appropriate for me at this stage of my life? That single question reframes the entire visit, from simply adding more to actively optimizing what's already there. And more often than people expect, it opens the door to a small adjustment that meaningfully lowers risk without taking away anything you actually need. Because at the end of the day, none of this is about fear, and it was never meant to be. It's about alignment, making sure the routine you've built over the years still matches the body carrying it out today. You may not be able to control every risk factor that comes with getting older, but you can control whether you ask the right question at the right time before a small mismatch has the chance to become something much bigger. Exactly the nudge they need. Sometimes the most meaningful change in someone's health doesn't start with a new prescription at all. It starts with a single overdue question about the ones they're already taking.